How was the snack? Are we all nice and cozy? A little bit sleepy? Should we do a stretch? Yeah. Like a wave? The Neonatal Resuscitation wave? You let me know. Oh, well, yeah, I'm at a wave. Yeah, that's on the needs. Just to get that, because our next speaker is, woo! Yeah, thank you, Gary. Okay, so the next speaker is Dr. Bobbi Byrne. She is a professor of clinical pediatrics in the section of neonatal perinatal medicine and the vice chair of education in the Department of Pediatrics. At Indiana University School of Medicine. She is an attending neonatologist at Riley Hospital for Children in Indianapolis. And at Indiana University, she serves on the Graduate Medical Education Committee, multiple branch review committees, and the board of the Daniel F. Evans Center for Spiritual and Ethics Grants. Nationally, Dr. Byrne is the chair of the AAP's longitudinal study of pediatricians project advisory committee. And she's also a member of the AAP NRP steering committee and serves as a neonatal content expert representative to ILCOR. Her educational interest is in simulation-based medical education, and she is the director of Neonatal Resuscitation Program and Outreach Education at her institution. She directs a statewide outreach education program to simulated medical sessions outside the university to community hospitals throughout Indiana. And she has successfully applied for several grants to support her work and has been honored with several teaching awards, including the Indiana University Trustee Teaching Award, the Morris Green Pediatric Faculty Teaching Award, and the Edwin L. Gresham Award for her work in education. We are incredibly fortunate to have Dr. Byrne here. She led the first ever simulation workshop at this year's symposium yesterday. So she's also, she's also a repeat Neo-Resus offender. She was here last year as one of our discussants for the same topic. Her title talked effective high fidelity simulation training with or without high technology, creating an opportunity to learn. Now, because Dr. Bobbi Byrne is so innovative, we will introduce our discussants now. We have two joining us, joining this conversation from the West Coast. First, we have Dr. Rachel Umaren, an associate professor of pediatrics at the University of Washington, where she is associate division head for research, the director of neonatal education and simulation-based training, which is also known as the NEST program, and medical director for the inpatient telehealth at Seattle Children's Hospital. Her pediatric residency and fellowship training was at Indiana University, and she also earned a master's degree in clinical research. She also has an advanced training in educational scholarship and quality improvement. She has been primarily interested in simulation education using advanced technologies, including virtual simulation, telesimulation, and this is now the focus of her academic work. She has contributed to the understanding of the virtual simulation in both high and low resource settings. We also have Dr. Nicole Yamada. She is a clinical associate professor in the Division of Neonatal and Developmental Medicine in the Department of Pediatrics at Stanford University. And she is an attending Neo at the Level 4 NICU at Lucille Packard Children's Hospital in Stanford. After graduating from Washington University in St. Louis, the School of Medicine, Dr. Yamada completed residency training in pediatrics at the University of California in San Diego and fellowship training in neonatal perinatal medicine at Stanford University. She also has a master's of science degree in human factors and ergonomics from San Jose State. Her research interests are in neonatal resuscitation, human factors, and improving human system performance in the delivery room. She completed a mentored clinical scientist Research Career Development Award, KOH, from the Agency of Healthcare Research and Quality to conduct simulation-based study of the effect of team training in standardized communication techniques on human performance during neonatal resuscitation. She has served as a content expert for the Neonatal Task Force at ILCOR since 2015. And she's also been a member of the American Heart Association Neonatal Life Support Writing Group since 2019. In addition to her research and clinical responsibilities, Dr. Yamada is a simulation instructor, a debriefing expert, and an associate director for the Center of Advanced Pediatric and Perinatal Education. So we're extraordinarily honored to have all of them as our speakers and discussants. So now I'll give it to Bobbi to take it away.
Okay, thank you so much. It's just delightful to be here. And I want to advance myself. Right, I'm just gonna say next. So, next. First, I don't have anything to disclose financially, but I do want to say that not only is it an honor to be at this conference with everyone who's so excited about neonatal resuscitation, because we are all very excited, I know, about neonatal resuscitation, but it's also an honor to be really in the same room as Marilyn Escobedo. Marilyn, you are a phenomenal mentor to all, but in particular to women in neonatology, in addition to just being an amazing person. So thank you. It's just delightful to be here with you. Thank you so much to the planning committee, Lauren and Clara and Eduardo and Chelsea and Nathan. You are so welcoming, and it has been such a pleasure to be here for the last few days, so thank you. Yes, it works. Okay. All right, so here are our learning objectives. First thing that we're going to do is we're going to try to talk a little bit about helping everyone recognize the evolution of technology in neonatal simulation. I wrote originally that it was going to be particularly in the last 2 decades, but I found all this really interesting information from a long time ago, so we're going to talk a little bit about that as well. We're going to describe some ways that simulation is being used in neonatology and in neonatal education. And then, because we have 2 amazing experts in Nicole and Rachel, we're going to have them work with me to discuss the educational effectiveness of using low fidelity versus high fidelity technology in neonatal STEM education. Okay, so technology and technological advances have played a really important role in our field as neonatal providers. If you review the history of neonatology, you're going to notice many, many milestones linked to technological advances. Things like the use of incubators, the ability to provide gavage feedings, things like surgical closure of PDAs, ventilation support and thermoregulation techniques. The list goes on and on, certainly well after this slide showing 19th and early 20th century advances. Of course, technological advances haven't always worked in our favor, and really more correctly in the baby's favor, truthfully. So an example of that might be neonatal incubators. So let's look at the history of that. We all know that neonatal thermoregulation and having the ability to do that in incubators or isolates is critically important. So the very first neonatal isolate or incubator, as it was called, is attributed to von Buhl, who was in St. Petersburg, Russia, around 1835. And at that time, he developed this relatively low-tech incubator. Subsequently, an OB and an engineer in Paris developed another type of incubator that was based on a model from a chicken coop that had little lights that warmed up the little chicks in the coop. And so that became some of the origins for the very first neonatal intensive care unit in Paris. Now, in the US, our relationship to isolates and incubators is a little bit more interesting, truthfully. So, interestingly enough, early in the 20th century, Dr. Martin Cooney, and by the way, he probably wasn't a real doctor, but you're going to notice a theme of ethics coming up. But Dr. Martin Cooney pioneered the use of incubators and saw acceptance for this technology by using it not in neonatal ICUs, but rather by showing this technology off on carnival midways, in fairs, and in other public venues. So here's a picture of some of those early incubators that premature infants are in. These infants were thought to be unsalvageable or weak. And so at times, Dr. Cooney and these incubators actually saved the lives of thousands of premature babies. Now, I'm not, by the way, endorsing this from an ethical perspective. However, Dr. Cooney never accepted any money from the families of these babies. And instead, he relied on these oglers to pay admission to get in, and that's how he supported the babies. I had first heard this story on an NPR StoryCorps, and I actually didn't believe it, and so I went and looked it up, and it was true. And so there are multiple different stories on it. If you have any time, maybe on your drive home today, you can listen to the StoryCorps story. Some of these survivors and their stories are really incredible, and this book is also on my list when I eventually retire and get to read again. Okay, but let's get back to incubators. So as the incubators further evolved, Dr. Julian Hess in Chicago would introduce an electric heated, water jacketed infant incubator in bed and publish his findings in JAMA, and that was in 1915. Interestingly, this Hess incubator had a little porthole that allowed oxygen to go in, but the system wasn't airtight, and so it leaked, and they never got 100% oxygen in these isolettes or incubators. The funny thing is that his rates of retrolental fibroplasia in the 1940s and 50s were much lower than those of other neonatal ICUs who had improved technology that didn't allow oxygen to escape. Of course, we know that that's now ROP and the effects of oxygen on ROP, but what an interesting thought that this advanced technology created a generation of blind premature babies. If you'll indulge me in one final picture, that's kind of an old time picture. This is Dr. Mildred Stallman, and I trained at Vanderbilt when Dr. Stallman was there. And she deservedly gets a ton of credit for advancing neonatal ventilation. But the nurses in the unit, the older nurses, when I was a fellow, would tell me about how neonatal nurses would stand literally between two babies that were intubated, and they would just hand bag them for their whole shift. I mean, I guess they got to sometimes, there were probably some rules about them getting to go and have a break or something, but they'd stand there the whole time and just hand bag. Can you even imagine that that's what your job would be? The nurses would tell me about how at least by their report, the incidences of pneumothoraces were pretty darn high, all in the name of us, advancing newborn ventilation techniques. But obviously, Dr. Stallman and her work and others' work did eventually develop wonderful infant ventilators that evolved over time. So, as I mentioned, there are many examples of technologies and procedures in neonatology, like in other specialties, that were considered evolved or state-of-the-art, and then found to possibly or probably cause harm. That's a lot of what we do on the NRP steering committee now, is try to find what are we doing, and is it causing harm? Is it really helping? What's the evidence for it, right? So similar to in our clinical work, technology and simulation education has been evolving, especially in the last few decades. However, simulation technology isn't new. So let's consider just a few of these things. In an article in Simulation in Healthcare on the early use of simulation in medical education, the author, Dr. Owen, commented that an oft-cited belief was that until recently, simulators used in education and healthcare were simple models. But that's wrong, because hundreds of years ago, and in some instances, thousands of years ago, we had intricate models that were used to help teach anatomy and physiology and in training obstetrics and many surgical disciplines as well. So around the year 1000, imperial physician, and I would apologize if any of you speak Mandarin or Cantonese because I won't get this right exactly, but imperial physician Wang Wei, who was well known and respected as a practitioner of acupuncture, wanted to create a standardized methods for teaching students this skill. So he created two life-size bronze statues for teaching surface anatomy and the location of acupuncture holes. And I think this is so brilliant. The mannequins, the models, the bronze statues, had 354 open holes all over the body where acupuncture needles should be inserted. So for the exams, you would fill the bronze statues with water and then cover them with wax. And then if you were the student and you had to take the test, if you inserted the acupuncture needle exactly into the hole where it needed to be, a little bit of water would drip out. So isn't that a creative and clever model and so intricate? Of course, it would be a little heavy, and I do community outreach, and so taking the bronze statue around would be a little heavy, but other than that, it's an amazing model. There were a lot of examples, I'm sorry, I think I went too far. I did. There are a lot of examples in history of carved anatomic wooden figures or wax models of things that we used to use as an homage, like wax and paper mache. And there's this early trauma sim that I read about. And again, I'm just going to say that I'm not endorsing, this isn't a talk about the ethics of simulation in medicine, but there was a king of France, and in battle, he sustained a horrible injury. He was impaled by a wooden object. And so his surgeons, the royal surgeons, really wanted to take care of him and help him. And so, because it was France, they guillotined several prisoners in the jail. They took their heads, they impaled them similarly with a wooden object, and the surgeons tried to practice getting that out. Again, not the ethics I'm endorsing, but interesting use of creative models for simulation in medicine. On a lighter note, or maybe a more practical or more ethical note, our OB colleagues have really done a great job through history in creating simulators. This one here is a birthing simulator model developed by Giovanni Galli in Bologna, Italy. And I think that it was around the year 250. And so what he noticed was that the surgeons were really knowledgeable, but the midwives who actually delivered the babies had a lot of expertise from their practical experience. So he developed this model, and in this model, this is a glass uterus with a small flexible fetus inside that they would need to deliver. And for the test, he would blindfold them and they had to deliver the baby blindfolded, which if anybody on my team is listening, I love that because sometimes I have my teams run sim blindfolded, and we can talk about that later, but I think it's a great idea. Anyway, this model you can see in a museum in Bologna. So this is probably one of the earliest examples of us creating a model to meet educational need. Another OB model is shown here. This is what would happen is they would take women's bones, so the pelvic bones, cover them with leather, and similarly take an infant skeleton, cover it with leather, and then use those as birth simulators. I can't speak to the ethics of this because they didn't comment on whether or not they got the bones from in a more ethical manner or not, but it does seem like a pretty clever model. And then finally, there's kind of an interesting model here that I'm going to tell you about. In 1890, there was a man who was walking along the Silk Road in Asia when he purchased a Sanskrit language text, and it was written on birch bark. And when he had it deciphered, it turned out to be a comprehensive textbook of surgery and medicine ascribed to Sushruta, an Indian sage and scholar thought to have lived between the 4th and 5th centuries. So on this slide, you can see some of the surgical skills and task trainers that were described in that really ancient text. So there's really a lot of innovations and really interesting examples of early simulation equipment, mannequins, models that were used. And over the years, simulation ended up evolving from training kind of lay people to training more medical professionals. For those interested in reading more, and I don't get any kickbacks for this book, but there's a book called Neonatal Simulation, A Practical Guide, and it's filled with lots of great examples of how to do simulation, but also it goes through some history of simulation, history of NRP as an example. And in chapter 20, or in chapter 32, the author will describe all kinds of influences that occurred to get neonatal simulation to where we are today, including some of those obstetric and anesthetic models that were used early on, as well as the influence of aviation and aerospace, which we'll talk about a little bit more in a minute. The author, Dr. Campbell, really outlines the transition of apprenticeship model around the turn of the 20th century. Medicine switched to this more apprenticeship model, and those who are my age or older will recognize the phrase see one, do one, teach one. And that was kind of our mantra for a long time. You know, when I was a very junior physician, they would say, if you've seen one, the next one you do, and then you teach it, and that's how we rolled. And we practiced essentially on actual patients. And so now our recent transformation to focusing on a combination of cognitive, technical, and behavioral skill acquisition, but in combination with reflection and improved practice in a really safe learning environment is certainly where we headed eventually. In the 70s and 80s, task trainers and mannequins were focused mostly on skill acquisition. There was a really nice umbilical vessel catheterization model that was pioneered by a young assistant professor at Indiana University, Dr. Marilyn Escobedo. This is not Dr. Escobedo as a assistant professor, but that was the oldest photo I could find if you remember. It doesn't look at the age, so it didn't matter anyway. She did this in combination with Dr. Rich Schreiner, who is shown here, who was my department chair for a number of years. And they wrote and published about many different task trainers and mannequins that they developed. Around the turn of the century, we started focusing more on this concept of improved teamwork, and so our mannequins need to develop as well, so that we could practice not just technical skills, but combining our cognitive, technical, and behavioral skills. And this is where Lou Halamik is going to start coming into the picture, and we're going to talk a lot more about Lou in a minute. Early manufacturers of mannequins included Medical Plastics Laboratory. If you think about all those old movies that you've seen in a doctor's office, there's always this skeleton hanging there, right, in every single doctor's office. Well, Medical Plastics Laboratory would create or manufacturer of those skeletons until a toy maker bought them. And that toy maker was Laerdal. Between Laerdal and Gammard, both of those companies really started to advance the technology in mannequin development. And then the real force behind advancements in technology for neonatal stimulation came along, and that is Dr. Halamik. We're going to talk about Dr. Halamik, but just I'm going to digress for just a minute and talk about Annie. So again, if you're my age or older, how many of you remember walking up to the mannequin during your PALS training going, Annie, are you okay? Yes, like some of us. If you're my age or older, you remember that, right? In the 1960s, Aslan Laerdal created Annie. And Annie is considered one of the most significant contributions to the development of modern day simulation equipment, especially mannequins. An interesting side note is, and I'm sorry if you have all heard this before, but I find this fascinating, that Annie, her face was based on a young girl who drowned in the Seine River. When she was found, she had this very calm, lovely face, and apparently Laerdal was so impressed with how beautiful and calm she looked that they had a death mask of her, and he used that to model Annie, which I think is really interesting. So there's these articles written about how Annie is the most kissed woman, like in the history of. Again, the ethics aren't important here, right? This is what we're talking about. In the 1980s, Armstrong Medical Supplies were the first to develop a whole body neonatal mannequin. And then in the 1990s, there were a lot more developments by multiple companies that increased the realism of these mannequins. Okay, so Dr. Lou Halamik, for those of you who might not be completely familiar with his work, is a neonatologist at Stanford. He's really credited with being the father of neonatal simulation. He worked with aerospace and airline industries, and he was really impressed with the crew resource management skills and techniques that they were using, as well as the simulation skills. And so in the late 1990s, he partnered with the aerospace industry and engineers to create a handheld computer that would interface with a bedside monitor so that he could control vital signs on a mannequin. This was really revolutionary because up to that point, neonatal mannequins were really completely low fidelity, and you had to have somebody embedded into the simulation to be able to kind of tell what the vital signs were to the other learners. And this, though, allowed the learners to have, be able to interpret vital signs on the monitor without somebody embedded into that scenario. So that's a big evolutionary step in neonatal mannequins and simulation. Of course, he continued to work with the industry, and he and others over time had many, many more improvements in neonatal mannequins and fetal monitoring, including improved airways that were much more realistic over time. I don't know if any of you are old, some of you who are my age are old enough to remember that the first neonatal mannequins, you could blindfold somebody and they could intubate the baby. And so it really became more imperative that we had airways that were more realistic over time in order to have an experience that was going to be considered valuable. In the early 2000s, we started incorporating behavioral skills into NRP training, and this is where simulation really gets exciting. So in the 2000s, the American Academy of Pediatrics and Lou partnered with Laerdal, and they worked to develop higher and higher fidelity mannequins that added much more realism and much more practical practice, especially for technical skill acquisition, as well as behavioral skills, when we had to interpret the mannequin, lead teams using behavioral skills and communication skills. At the same time, Umaren, also another company that was working on developing computer-controlled pediatric and neonatal mannequins, and in 2004, the very first tetherless and wireless adult mannequins, which were relatively shortly thereafter followed by neonatal mannequins, were developed. You can imagine that having a tetherless wireless mannequin means that we have so much more ability to move around. For me, it changed my career because we can go out and teach outside of the academic center without having a ton of bulky equipment with us, which is what we originally started out with. And so now technology continues to advance so that the very first babies looked more like 6 or 9 month old baby, and now they look smaller and smaller, and we even have preterm babies that have fidelity, that have some degree of fidelity. So it's getting really exciting. The way that he ends the chapter, or as he's nearing the end of that chapter in the simulation book, is that he talks about something similar to what I alluded to in the beginning, is that technology itself isn't a panacea though, right? And only when it's purposely paired with educational theory and reflection can practice improve. And our ultimate goal, obviously, is enhancing patient care. So as mannequins improved, we also had many other things developing, right? We were doing things like simulation instructor courses. When I say we, I mean Lou. We were starting to video record scenarios more. We were doing more and more research in simulation education. And we had this continued evolution of our mindset, and we've heard multiple times today how it takes a while to develop a mindset, but we had this evolution from this apprenticeship model of I'm going to see one, do one, teach one, to this interprofessional team functioning model where I've practiced this in simulation, and I've practiced it several times, and I feel pretty good about my skills, so now I'm ready to be involved in a real patient care. This leads us to, although I think that I forgot to tell you what I want to say about Lou. I took Lou's simulation instructor course at CAPE 11 or 12 years ago now, and it changed my life. That's the truth. Mostly because he taught me debriefing, and it's so much more effective when you debrief your husband instead of telling him what to do. So it has dramatically changed my life, and with my children too. But in all seriousness, it's changed the lives of millions of babies, because Lou has really pushed forward this philosophy of not just having technical skills, but having behavioral skills and having us practice in a team training model. And I truly believe that he is the reason that many, many, many babies are going to do better in their lives and have a better start. And so I'm very thankful for him. And he developed, certainly changed my career as well as multiple others. So very thankful for him. My team used to think that I was in love with him, and I'm really not. Like, I love my husband, I just think Lou is really awesome. All right, so this leads us to NRP, because NRP, it's important to understand that simulation and mannequins, of course, were around before we developed the NRP program, but NRP is really the biggest push toward having simulation become a huge part of our curriculum and our educational process. So from biblical times to the 1700s, there's all kinds of documentation of mouth-to-mouth resuscitation of newborns. And then into the 1900s, even more newborn resuscitation techniques had been documented. And then in 1963, a German physician filmed a neonatal resuscitation where an infant received positive pressure ventilation and intubation. And that was one of the sparks that made us say, well, wait, who should be teaching neonatal resuscitation? And how do we standardize this education around neonatal resuscitation? So in 1985, and we've talked about this a little bit already, the AHA and the AAP convened a group of experts that eventually started the Neonatal Resuscitation Program. In 1987, the first NRP textbook was distributed. And this is the first NRP algorithm from the very first edition. And I had thanked Bina for giving me this in the archives, but it's really, you can see already, you recognize this flow diagram that we still use today, although clearly there are some fairly significant changes from this to our current algorithm. Right. So although some simulation did start prior to NRP, this national initiative to standardize newborn delivery room care and have one professional trained in neonatal resuscitation at each delivery, eventually we recognized in NRP that we really needed to include cognitive, technical, and behavioral skills. And so in 2010, the NRP committee formally integrated simulation into NRP. This, I won't go through all of it, but our guest, Nicole, as well as Lou, authored chapter 3 of the guidebook, and it is on the evolution of the simulation and the neonatal resuscitation program. And I would really highly encourage you to read it. It's fascinating. They talk about why simulation is so important in our education. Lou certainly changed the whole paradigm, and he talks a little bit about that in the chapter. Nicole and he talk about how things that drive simulator development and design, and they also have a couple of brilliant charts on some of the desired features that we all want to have in our full-term and pre-term patient simulators, as well as describing the current state of simulation in the NRP. I suspect that that will evolve very rapidly in the next several years, and so read it now while it's still up to date for the current state of simulation in NRP. So there are many studies on simulation and NRP training, right? Technical and behavioral skills that are being studied, anticipation and prep. So these are articles that use simulation as examples to try to talk through what we're doing. Integrating both neonatal with obstetric simulations, having multiple different providers, having different levels of providers, right? There is quite a bit of research in NRP training in simulation. So where else is sim used in neonatology? One of the ways that sim is used certainly is to improve procedural skills, and we've all talked about that, right? But we know that improving procedural skills are not the only thing that we want to focus on, right? We're considering not just the improvement in technical skills, but we're looking at how those skills reinforced in simulation may or may not translate to the clinical environment. We're looking at what technologies outside of mannequin development might assist with simulation education. We're always considering the gaps in our education and knowledge and finding ways to improve our practice. We're considering ways that simulation might add to our understanding of resuscitation, especially in areas that can be difficult to study given the infrequency of their occurrence, such as in chest compressions. Or ways we might consider providing volume expansion in a resuscitation. We're taking simulation outside of the academic center and into our communities. And we're using telemedicine to take simulation-based education even further. We're using simulation education in simulated environments to help improve our patient care and the patient care environments we work in, and the way that we work together as teams and the way we interact with our environments. And of course, we're always looking for ways to improve our simulation experiences. Dr. Byrne, our panelist, and her colleagues in Seattle, in a way almost turned back the technology dial by using real human umbilical cords for training, much like I did as a fellow before we ever had mannequins. And so I know the other thing is that Dr. Weiner talked a lot about the use of AV and VR, telesimulation, and so certainly there's so much technology that we're using in simulation today. I want to just take a minute to talk though about fidelity in simulation, because the term high fidelity simulation isn't really used consistently throughout the simulation literature. And so I think it's important for us to think about what that is and what that means. Because there are a lot of studies that talk about measuring the influence of fidelity on simulation, but it's not always clear what they're defining as fidelity. So we've studied the effects of high fidelity on simulation on like student confidence, on anxiety levels. We've compared it to using lower levels of fidelity. We measure its impact on knowledge and skill acquisition in nearly every healthcare discipline and at every level of learner. So let's talk for a minute about the ideas of fidelity and modality, because they're two critical components. So fidelity really doesn't simply refer to mannequins, because a lot of people think high fidelity simulation is using a mannequin that has a lot of bells and whistles. But in fact, fidelity can refer to the environment that you're conducting the simulation or education in, right? And the realism in that environment. It can be referring to the technology like mannequins, but in addition to mannequins, other hardware and tools that are used or software packages, so that we can give a better feel for being in a real clinical practice environment. And certainly there's psychological fidelity, right? So that we try to enhance the learning experience and create a more realistic environment by having emotional and behavioral aspects of simulation incorporated into our education. There are lots of other examples of fidelity, and there's all these new eye tracking softwares out there and all kinds of really fun stuff that we don't have time to talk about. But fidelity is a little bit different than modality. So what's modality? So modality refers to the type of simulation equipment or methodology used. So for example, are you using task trainers? Are you using standardized or simulated patients? Are you using full body mannequins? Or are you doing screen-based simulation, simulation? And fidelity, though, again, is more associated with the realism. Okay. So high versus low fidelity. There are many articles, like I mentioned. They've looked at every subject regarding high and low fidelity. How does it affect learners? Which one's better? Is it superior? But is it superior but leads to overconfidence? They do randomized trials, right, in neonatal resuscitation, and they do all kinds of high versus low fidelity things. It's everywhere, right? So what I really want to think about next is talking about high versus low fidelity. And this is where I'd really like Nicole and Rachel to come in, because I have a couple of questions that I know that, I feel have some fairly strong opinions on, but I'd love to hear more from them and from you about these subjects. So if Nicole and Rachel are ready, I'm gonna ask the first question, if that's all right.
Hi, Bobbi.
Hi guys, how are you?
Doing well. We were trying to get our videos on earlier. Hopefully they are on now. There we go.
Yes. Yes, there you are. Good. It's good to see you.
Likewise.
And is Rachel up? And I'm just not seeing her.
Well, I'm up. Maybe Nicole is pinned, but I think I'm also there. I am. There we go.
Hey. So guys, one of the things that I really like to think about when we're talking about fidelity and simulation is that there's a lot of research that shows that learners love high fidelity simulations. And in fact, a lot of facilitators do as well. But when we consider it, really, more isn't always better. And so the question I wanted to ask you guys to start with is, how do we avoid this fidelity trap, if you are following what I'm asking here?
Nicole, do you want to take that, or
Sure.
would you like me to? Go
We
ahead.
get this question a lot at CAPE in our simulation instructor programs, because especially for people who are starting up simulation programs or centers and want to know which mannequins to invest in, because some of these mannequins can be so expensive. And the thing that we always start with is, what are the learning objectives that you need to achieve for your learners? Because that really should guide what features are needed in the mannequins or even the rest of the equipment in the environment that you're using. And so actually starting with not necessarily what is possible, but what is needed can really help people to hone in on what's needed for their program, and then use that to guide choosing whether or not higher or lower fidelity might really be required. I would say that Lou actually really dislikes the term of high fidelity or low fidelity. It's usually more complex or less complex, because you can certainly achieve a very realistic simulation with very little technology and bells and whistles.
Yeah, I think I'm going to agree with this one, although perhaps you were expecting a different response from me, because I do a lot of work with technology. From the standpoint of thinking about what we are trying to achieve with simulation, simulation is a technique. It's not a technology, and a lot of people approach it from the lens of, okay, I'm going to have this fancy mannequin and it's going to do all these things, or I'm going to design this really super realistic virtual simulation in which the learner is going to be completely immersed and it's going to feel really real to them. But what we've actually found over time, and this is not just recent literature, this is literature over the last 10 to 15 years, is even with virtual simulation, which we would consider super high tech, the level of realism does not really affects the outcomes from the learning standpoint. You can have relatively low realism, but if it matches the level of learner that you're targeting, and it matches your educational goals, you can have excellent learning outcomes. So again, thinking about the umbilical cord model that you talked about, that is actually a very low tech but very high fidelity model. And far better than a cord that you would get on the highest fidelity mannequin that you could think of as we think about the high tech mannequins. So I am with Nicole on this. You have to target your learner, you have to target your scenario, and you will ultimately land in the right place with your technology and the fidelity of it.
I have total confidence that you would agree with this. So now, I know that you do amazing work, and you do use a lot of complex and high fidelity equipment, but I knew that you would agree with this. So thank you. That's perfect. Team, are there questions from the audience or Clara from the chat before I continue to be selfish and get my questions answered?
Green light to go.
Okay, super. Maybe you can advance it on. Yeah. All right. So this is related. There's definitely a potential bias toward using higher levels of fidelity among educators and learners, like we talked about. And one of the problems is that students really report higher levels of satisfaction with high fidelity and believes it provides advantages over simulation-based learning that uses lower levels of fidelity. How do we help our learners to really embrace lower fidelity simulation, especially in environments like our academic environments where they're surrounded by higher fidelity simulations quite often?
I do think that the approach the facilitator uses, setting the stage and explaining, the goals of the activity is super important. It's probably more important than the mannequin or the platform that you're going to be using. Again, it's entirely possible that, these learners are reporting high levels of satisfaction because they had excellent facilitators, not because they had excellent mannequins. So it just goes back to the instructor and, what are they bringing to the experience, and, how are they navigating that experience with the learners and ensuring that there's excellent debriefing happening as well. So I think it's the whole package. It's not just the device or the mannequin.
I would agree with Rachel too. My thought in reading this question, my first thought was going back to the expectations that are set at the beginning of the learning experience or the training program by the instructors or the facilitators. One of the things that I think is really important is to emphasize that the mannequin should be treated as a real patient. And so I think saying those types of things and explaining to the learners that the mannequin will respond as a real patient in terms of the vital signs that you might see and the physiologic responses to interventions, and really treating that as such as the resuscitation or the scenario progresses really helps, I think, the learners to buy in. I think as an instructor team at CAPE, one of the things that we often kind of remind each other is that if a group of learners isn't doing the right thing, the patient won't get better. And so that can help to sort of reinforce that approach to the learners as well in the responses that they may see from whatever mannequin of whatever complexity that they're using.
I guess I want to turn the tables here on this one, Bobbi, and company, in case anyone wants to weigh in on this question. Like Nicole said, it's how you set the stage. Where are we going in the field with the concept of how do we further standardize our pre-briefing with learners to ensure that we have the outcomes that we're desiring post-sim.
You got anything else from the floor, please? All right, so this is a statement that I see sometimes, and I'd like your opinions on this. Oops, go back one, I'm sorry. Although advancements in technology allow for sometimes more authentic scenarios, the cost of high fidelity mannequins and resuscitation equipment completely limits its availability and access. What do you think? Is that true?
The true or false question?
Sure. Should I give you multiple choice?
I would say true. If I had a choice. Now, that said, there is a little bit of an exception there. So I think earlier we probably heard a little bit about some of the, I would say, more high tech, therefore slightly more high fidelity mannequins that are currently available. They resemble the Neonatal, which is, I think we're all familiar with, is the lowest of the low tech mannequins. It still actually has a lot of features if you've ever used one. But now being able to capture really detailed data about positive pressure ventilation, still within a mannequin that is able to withstand environment and use and long battery life and all those things that you need in a setting that is low resource. And yet, cost wise is a fraction of the price. And again, this is what they tell me of the high fidelity mannequins that we use more routinely, which run into tens of thousands of dollars. So can we get there? Yes, we can. I do really think it's possible to, over time, with technology advances, decrease the cost of high technology tools and solutions. I mean, we've seen that happen with VR becoming much, much more accessible over the years, even to the level of a simple mobile phone, being something that's in the hands of nearly every healthcare worker around the world. So I guess I will put an asterisk next to yes, meaning that I think we can get there over time.
Nicole, I'm gonna, there's a question in the chat that I'm not 100% interpreting this correctly, but I think that I am. When somebody participates in a live patient resuscitation, how does that compare to resuscitation in a mannequin or in a simulated situation? I know that there's been some nice work out of Stanford done on that, and I'm sure elsewhere as well. Do you want to talk about that a little bit?
Sure, I think I see the question too. I think is the question may be getting at kind of the learning that might be possible in participating in real patient care compared to in a simulation on a mannequin. And I think that does get to some of the points that you've already brought up as far as the fidelity or the realism within the environment itself. I would say that in my personal opinion, I think that it's very much possible to make a simulated resuscitation on a mannequin be just as valuable as a real resuscitation on a real patient. And potentially with the opportunity for debriefing that's available in simulation, the simulated experience may be even more valuable if there is not a similar opportunity or time for a debriefing after a real resuscitation, because the learning for most resuscitations, really the bulk of that occurs in the debriefing. There certainly is the opportunity in simulation when the procedures are actually being performed for people to practice those hands-on skills and really get some of that technical skill practice. But so much of the learning around what makes us skilled resuscitators and skilled resuscitation teams comes from learning how our teams work and what makes us good team members to one another so that we can be an integrated group.
I love that point, especially about the debriefing. We were talking yesterday briefly about how they here are trying to debrief after their resuscitations, but that there are some barriers to that. For example, a really busy call night and how it's difficult to get the team together and things like that. So that the simulated environment is a great place to learn through debriefing. So thank you. Is there a question?
I would like to actually add to that to say that this is more recognized perhaps in the nursing world where for a student nurse, the simulation hours that they spend in the sim center are actually counted, same as clinical hours. So I feel like, we may be a little bit behind in that regard, like fully embracing the power of simulation for education, as so close or somewhat equivalent to the live experience.
Thank you. Hi. In thinking about what you're describing, what Nicole was describing as sort of a team dynamic, learning together, doing the debrief, that's where a lot of the learning happens for our residents, fellows, even for us. But really even thinking about how we can break down resuscitation scenarios into just the procedures. So I'll say that, because you were saying that fellows and residents, learners prefer high fidelity. But I use a styrofoam cup and expired pigtail kits, and I have our residents just do pigtails on this cup. I have them do it over and over, and while they laugh and they roll their eyes and like, this seems so silly, it's really the dexterity of managing the pigtail and inching it forward and knowing the order of what you're doing. And so I think when we talk with our learners about what the purpose, what are the objectives of each simulation opportunity are, I think we might get more buy-in from them when we remind them that some things we do need high fidelity. That's the only way you're going to get that experience, that sort of your heart rate's going to start going up. You're going to feel like, oh my gosh, this baby's going to die. And then, you learn about that at the debrief. But having an opportunity to work with our learners and breaking down those resuscitation scenarios, I think can be another really great way. And I'm just wondering what are some of the other sorts of things that we can just do with stuff that we have around. Do you all have any suggestions about that?
So I'm sure that Nicole and Rachel do so, but we develop, our team develops multiple very low fidelity but important mannequins. So we have a pneumothorax task trainer. So we took a skeleton from after Halloween, we bought little skeletons and we took the thorax out and we opened up one of our old mannequins and put the thorax in, and then we covered it with there's like a little bit of styrofoam foam to kind of simulate the lungs. And then there's a piece of plastic so that it kind of feels like the pleura. And then there's another layer of fabric that feels like you're popping through it in the skin. And so it's just a little bit of fabric, right? But it really feels, you know that feel like when you pop through and you go through a little bit more. So we have a lot of those that we do. We have a pericardium trainer as well. That's a balloon filled with red sand. And then that balloon is put inside another balloon that's filled with yellowish liquid. And then that's tied and put it in the chest. So when they tap the heart, if they get into the pericardial sac, then they get yellow. And if they go the whole way to the heart, they get red. And so we do a lot of low fidelity things to help train. We take all those old mannequins that nobody uses anymore, and we convert them into these. And I'm sure Nicole and Rachel do a lot of work as well with that stuff.
Do you mind if I just?
Oh, please.
Do you mind if I just make a comment too? Because this is a little bit less, I'm one of the fellows here at OU, but recently one of our numerous attendees started having code blue sims in the unit. And so he would kind of give us a little bit of a heads up, like, hey, soon we're going to do another code blue sim. And we expect you as the fellow to run the code blue. So whenever it happens, whichever one of us kind of gets there first, does and runs the code
So you walk
blue.
really, really, really slow.
No, we run. We want to do it. But yeah, so it does feel real because you don't know that it's real or not, and then you get there and you see the mannequin. But I mean, it's nursing staff, everybody, like, it's a real code blue cart, all that stuff. So it definitely feels very high fidelity, even though it's our like most basic premature mannequin, quote unquote. So yeah, I think that you can do a lot of high fidelity sim that feels very realistic.
Inside you is very high fidelity, right? Because it's that environmental component that's high fidelity. And especially when you're using all the equipment that you really use in the real environment, that really hits, it's the realism, right? So it's very high fidelity despite being a low fidelity mannequin. Agree 100%. That's where environment is really important.
I guess I have a
Another-
question when you're.
Before we move on, another resource for the group to look into, just to kind of add to what Bobbi was describing about the various kinds of models and mannequin, low resource, low costs models that can be used to create high fidelity experiences is the Society for Simulation in Healthcare every year has a Simventor showcase. And that's a great opportunity if you've created one of these models to actually, turn it into educational scholarship and get it out there, as an abstract, because then you get to, when we were doing this in person, show everyone your model, get feedback, and, get people really interested and engaged. And then for those of us, that are just interested in figuring out what's out there, it's a great opportunity to see how everyone's being super creative. And, with the advent of 3D printing, there's a lot of 3D printed models now, and those are, again, much lower cost than having to purchase them.
Thanks, Rachel. Yeah.
Yeah, so just a question about high fidelity. So you're saying that learners are in general appreciate high fidelity more, rank it highly, but the flip side of that, I guess, that I find is that when your high fidelity mannequin doesn't work right, that is such a huge dissatisfier. It's one of those pluses and minuses. Yes, you're giving them this great experience, but when it doesn't work, when they're feeling a pulse, it's not what the scenario is supposed to be, and you're trying to tell them, no, it's 150, and they're feeling the 60 heart rate. It's such a defeating experience. And I wonder, I just wanted some opinion from the panel on that. That's one of those pluses and minuses that we have to deal with when we're doing with these high fidelity mannequins. Because I think that's probably one of the worst experiences for the learners, is when you're trying to debrief at the end and say, I know the mannequin didn't do what it was supposed to do, but really, really, you were doing a good job. And they're defeated and they feel awful because it just didn't respond well.
Yeah, we have the same thing happen all the time. Every time we run a neonatal seizure and the mannequin, you practice it, and the mannequin, and then we get in the scenario, So it's frustrating, but I think that this is where, when I made a comment a little earlier in the class or in the course about we need people who are skilled in facilitating simulation, right? Because a skilled facilitator will be able to step into that scenario and act as an embedded participant to help get this scenario back on track. And so we, in our simulation instructor course, we do a big section on how important embedded participants are, because I think that a good embedded participant can go in and say, I'll feel the heart rate for you now, and I'm feeling, okay, it's 150. And so really making sure that they know how to take over or help in the scenario, or, you know, we always have somebody in the room if we're gonna run a neonatal seizure, because when it doesn't work, the person will say, I am feeling clonic movements on the baby. I'm seeing it bilaterally or, you know, in all four extremities or, you know, whatever it is, so that if we have skilled facilitators, I think we can overcome some of those, not always, we can't overcome every single issue. We were supposed to have a bleeding artery, and the baby was exsanguinating out, and we had this pump and the blood was supposed to spurt, and it worked beautifully, and of course it didn't work in the scenario, and there was really almost nothing we could do, except we just went in and poured some blood on it and said, okay, but you're right, Nathan, it's hard sometimes to overcome, but I do think skilled embedded participants can really improve that process for us. Nicole and Rachel, do you have other comments?
I think that's also a place, as you're saying, for skilled facilitators, even if you don't have the resources to embed them in the scenario, those are challenges that can be addressed in the debriefing. And so, you know, one of the things that I think is a challenge is sometimes the learners, especially if they're kind of skeptical of sim in the first place, then if something doesn't go right, they think that perhaps there's like that the instructor was trying to trick them. So one of the things that we always do is, if it's really something that's been frustrating and really sort of took the scenario in a completely different direction, that we would admit, like, hey, this is what we intended for the mannequin to do. We intended for the mannequin to clearly be seizing, and then it didn't. But, you know, admit that and then move on. Still try to address in the debriefing whatever opportunity for learning you were hoping to create. And similarly, there are certainly times where you may have something clinically that you wanted to happen coming from the mannequin, some type of cue, but it was difficult for the participants or the learners to perceive. And very often it's easy to kind of turn that into a real life situation. You know, how often is it really clear what the heart rate is when somebody's auscultating? Or how often is it sometimes uncertain that whether or not breath sounds are equal or unequal? And if you get the learners to sort of use that sort of defect in your own scenario, and these are situations where you may not even have to admit the failure of your mannequin, but you can really just turn that frustration back on them and say, okay, well, have you ever been in a situation where it was difficult to auscultate breath sounds? What other cues or what other data points can the team look at to see whether or not the infant is being effectively ventilated? And now you've actually turned this challenge that you were thinking was potentially catastrophic in your own mind into a really great learning opportunity and opportunity for discussion for the whole team that even just moves beyond whatever challenge or hiccup may have come from the technology.
Hi,
Yes.
it's Colin here.
Yes.
I want to come back to the discussion of fidelity, I'm afraid. But I was thinking about the discussion we had yesterday, the difference between deferred, delayed, optimal, natural cord clamping. And I feel that an issue when we discuss immersion, fidelity, realism. And I wonder how you think we can bring some logic or rationale to that. And maybe the people in simulation have a logic or rationale, but I'm sure that when people listen to you and they hear the term fidelity, they think of the technical fidelity, they don't think of the realism or the contextual fidelity. Is there some way, or do you have suggestions on how we can standardize that?
I'll make one comment and then have you two comment. I think clearly when we are doing research and we're publishing it, that we need to be very clear on when we use the word fidelity. And it's a little bit of a buzzword, right? You have it in your, the headline is, you know, high fidelity versus low fidelity. And then it's not necessarily clearly documented or explained within the manuscript. And that's not where we need to be, right, anymore with SIM. We're more evolved and advanced than that. And so ensuring that when we are publishing our work in simulation and techniques, that we're very clear on what we're referring to when we talk about fidelity. I think that would be one thing that could really help, because right now the literature, we publish things that are all over the place on this. Nicole, Rachel.
I agree. One of the best resources out there right now, if you're kind of trying to figure out terminology, is the Healthcare Simulation Dictionary. It's free on the Society for Simulation Healthcare website. And it has definitions for all these things. I mean, I was amazed that it had, very, very solid definitions for all the other types of simulation that are out there, the VR and AR and mixed reality and hybrid. And, so it's a great resource. And I think if we are consistent, as Bobbi said, with our use of technology over time, we will be able to utilize a resource like this to kind of stay on message with what we really mean when we're referring to high fidelity or high technology and so on.
Rachel, do you know if they're updating that regularly? I don't know that. I like the dictionary, but I'm not sure who's responsible for it.
So the second edition was just released this year, so it is being updated.
And
yeah, so my question for you on the panel is, when do you feel that you need to move to a technical, I would say high-tech fidelity? In which scenario do you think that the low fidelity has limitation and you really feel uncomfortable to continue doing low fidelity management, I would say, for your simulation, even with high realism on it?
my personal opinion is that once you have a fairly good foundation of your cognitive and technical skills, to branch out more into trying to enhance realism so that we can start working a little bit more on emphasizing behavioral skills, then the fidelity of the scenario and the mannequin and the environment becomes important. So as an example, I'll take the interns over to the simulation center and let them work on newborn resuscitation there. But eventually, when they get better, they'll be running newborn resuscitation scenarios in the unit with nursing and respiratory colleagues. And so it's a higher fidelity environment, whether or not it's a high fidelity mannequin or not. But if you want to practice teamwork, behavioral skills, communication, leadership, then I think that the higher the fidelity or realism, the easier it is to try to get people to be immersed in that. Nicole or Rachel. Bobbi, we have a few questions from the chat.
So along the same topics, there are some questions about the use of certain equipment, like digital or amplified sound stethoscopes in sim. Is that helpful? Is that optimal? What are your thoughts?
Nicole or Rachel, do you want to do that? Could you hear this okay?
I think it's important to have people train with the equipment that they're going to use. This particular question sort of mentions the idea of staff members who are rotating through different hospital settings where there's different equipment in each environment. And I think that is a huge challenge for anybody, because being familiar with your equipment is an integral part of any team performance. And so if individuals there have very varying familiarity with the equipment that they're going to be using, then that can affect their outcome and their performance, because they're going to have a higher cognitive load as they're trying to interact with different pieces of equipment that they may not recall all the functions of. So I think that in an ideal setting, that there is an opportunity for an individual who may have to rotate through multiple settings to practice or run simulations with the equipment that's available in each setting. It may not require a full up sim, if we're going to talk about high fidelity, it may not require walking into an exact replica of each, of 3 different hospital rooms. But if, for example, there's a different T-piece or neopuff device that's being used at each hospital, then it would be important for each of those pieces of equipment to be something that the healthcare provider has an opportunity to get hands-on and practice with.
I agree. I actually had this brings to my recent experience. we were doing some just-in-time training on using direct laryngoscopy with one brand of device, and turns out the device that was available for the actual intubation was a different brand, and they look very different and they handle very differently. So I do think that the point Nicole makes is very valid.
I think Rachel just kind of brought up a nice term, which not everybody may be familiar with, which is this concept of just-in-time training. So I think some people may be familiar with simulation and the concept and the construct of reviewing NRP and renewing the NRP card that we each get every 2 years. But there's also an opportunity in situations where we perhaps can anticipate needing to be familiar with a certain case, preparing for a baby with a prenatal diagnosis of any specific congenital anomalies, or similarly back to this question, rotating through a hospital that you only work in once a month. When you arrive there, part of what you can do before the beginning of the shift is give yourself your own just-in-time training and sort of review the different pieces of equipment that you maybe aren't as familiar with using from your other work environment. So I think we often think about simulation as being one big simulation scenario, but there's also the opportunity to just think about using different pieces of equipment, again, based on what are the learning objectives. My learning objective is going to be, I'm walking into this hospital that I haven't been in a month. Let me refamiliarize myself with the warmer and the T-piece that are going to be on the bed there.
And to add on to that and what you had mentioned earlier as a fellow, in situ simulation is a brilliant way, right, to address a lot of these concerns. Because when you simulate in the environment that you actually work in, there are certainly some barriers and potential limitations to it, but overall, it's a fantastic way to be able to do that.
I think one of the examples the best case was just talking about a lot is about the conjoined twins, and we are actually having some of these deliveries, and we can be innovative and we can try to simulate the scenarios and how to be creative and get it incorporated. Another thing I don't know whether audience knows that Dr. Lou Halamik was one of the first speaker on the Neonatal Resuscitation Symposium over here, and at that time we talked about also developing some verbiage unable, rather than having a lot of speaking in the real time, in the real delivery room, and having how to make it succinct and how to make it. And I know that Clara and Nicole and we have been talking about this for a while now. I don't know whether academy is doing anything, or NRP is anything focus, any advances in that particular area.
In trying to make more kind of succinct
communication in the delivery room.
We've talked about having the recording sheet for a long time to help with our communication and direct communication in the delivery room. Marilyn, you might be able to help answer that more if there's something specific that we're trying to do. We're putting example videos and simulation scenarios on the learner or instructor toolkit, and so that should be helpful. But is there anything else you can think of?
No, I don't think we've gotten to that point yet, but I think Nicole will remember that when Lou would look at the Miracle on the Hudson and show the clips of the way pilots communicate in terms of in these terrible emergencies, and they all communicate very succinctly, and I think that's what Virgie was talking about. And I know Nicole did some work on this, but I don't think we've gotten to the point where we've actually developed what those words should be, but they are not like well, I can't quite see the chords. I tried once, it's not quite there. Maybe you should try, instead of just saying, I can't do it, here's the, just pass it off. So I think there is a need for it. And I think at some point we'll come to that. What do you think, Nicole?
Well, the work that I'm doing is trying to look at if we do standardize communication and make it more concise, does that actually help people adhere to NRP better? That's still in progress, but my pie in the sky dream is that I can prove that it is effective so that I can convince the NRP with some actual science that this is something that should be more formally implemented. The argument that I make when I am teaching my teams who are in my intervention arm about this is that we have behavioral skills that we know our 10 key behavioral skills are part of NRP. And one of them is about effective communication, but we actually don't get anything more regarding specifically what does that communication sound like? And what are some words or phrases that we should be using so that we all have sort of a uniform lexicon that we are both using and expecting to hear from the people that we're working with. So I think that that's useful. Of course, I'm biased, but I think that that is something that could definitely be considered part of team training, of rather than just learning that kind of how to work together as a team, but what are some more specific ways and strategies that we can teach our teams to really be high performing team members.
I think closed loop communication is part of that. I think closed loop communication is part of that as a strategy. What's the heart rate? The heart rate is 150. I need help. Will you call for help? I have called for help. They're on their way. So I think we do have some things, but just not enough yet.
Well, this has been a wonderful session, and I want to thank Bobbi and Nicole and Rachel for a wonderful